Myself, Dr. Jibran Ahmed presents to you Simply Pathology, and today we are back with a very important lecture. Today we are going to discuss about the final session on the peripheral blood smear, that is the morphological evaluation of the red blood cell. Now this is a very important session because in this session we are going to discuss the basics of the morphology of the RBCs and its variation. So it is very important both for the undergraduate as well as the postgraduate students because a lot of basic questions are asked from this particular part. So stay tuned till the end of this video. If you see, first before we go into the morphological variations of the RBCs, we need to understand how a normal RBC looks like. For that, we have to examine in a particular area. So RBCs are best examined in an area where the red cells are just overlapping each other or just touching each other, as we see over here. So over here, if you see a normal RBC, so suppose we take this normal RBC, so you will see that the outer area of the RBC is staining deep pink in color, okay, whereas if you look at the center is clear. So this is called as the central pallor, okay. So having a central pallor is normal, but how much? So the central pallor should constitute no more than 1/3 the diameter of the RBCs, okay. So red cells are best examined in an area where they are just touching one another towards the tail of the film, okay. The normal red cells are 7 to 8 micrometer in size. They are round with smooth contours, as we can appreciate over here, and they stain deep pink at the periphery and paler in the center. Now, how much the central pallor should be there? So the area of central pallor is about 1/3 the diameter of the red cell. So how do you judge the size of the RBC? So I have already explained this point before. I am repeating once again. The size of a normal red cell corresponds roughly to the size of the nucleus of a small lymphocyte. So the normal red cells are described as normocytic, that is having a normal size, and normochromic with normal staining intensity, that is normal amount of hemoglobin content. So now we are going to discuss about the morphological abnormalities of RBCs, which can be grouped under 6 main headings. So what are the headings? So we will discuss the red cells with abnormal size, red cells with abnormal staining, red cells with abnormal shape. Then we are going to discuss about the red cell inclusions, immature red cells, and abnormal red cell arrangement. Okay, so we are going to discuss each one of them with the help of beautiful diagrams, so to explain you each and every concept very clearly. So the first very important heading is the abnormal red cell size. Okay, so RBCs with abnormal size, so increased variation in the RBC size. So the what is it called as? It is called as anisocytosis. And increased variation in RBC shape. Okay, what is it called as? It is called as poikilocytosis. Now you will not believe, in the exam you are that much stressed that you do not know the difference between anisocytosis and poikilocytosis, and you tend to make mistake. The most common error is you mistake anisocytosis for poikilo and vice versa. So always remember, whenever it is a variation of the size, it is anisocytosis, and whenever there is a variation of the shape, it is poikilocytosis. The above two changes is a feature of most of the anemias, and remember, it is a very non-specific finding. So you might see this in iron deficiency anemia, and you can see the same thing in hemolytic anemia as well. Okay. So a raised RDW is the red cell distribution width. So whenever in the machine report, in the 3-part analyzer report or in the 5-part analyzer report, if you see that the RDW is raised or increased, okay, it is indicating anisocytosis. Okay, what is RDW? What are the types of RDW that you see? We will discuss that when we discuss about the automated cell counter and its interpretation. Okay, right now we are just concerned with the morphological examination of the RBCs in the peripheral blood smear. Okay, so if you see over here, microcytosis means if this is a small lymphocyte, and if you look at the nucleus of the small lymphocyte, the RBCs as compared to the small lymphocyte, they are smaller in size. Okay, so what are the conditions where you see this microcytosis condition? So the basic mnemonic is CETA. So you must be knowing about this. This is not a very new mnemonic. It is a very commonly used mnemonic. So S stands for sideroblastic anemia, I stands for iron deficiency anemia, T stands for thalassemia, and A stands for anemia of chronic disease. So this is a particular diagram. So over here, I just want to show you what is anisocytosis. So there is a difference in the size. So if you see this RBC, look at this size, look at this size. Okay, so there's a difference in the size of the RBC. This is called as anisocytosis. Okay, this is another image which is showing what is called as microcytosis. So what is very important over here, this is a small lymphocyte, as we can appreciate. Now this I have, I have chosen this particular diagram so as to compare the size. Now look at the size of this RBC and compare it with the size of the nucleus of the small lymphocyte. Absolutely it is small. So this is called as microcytosis. Okay, so if you see, this is a classical slide of iron deficiency anemia. Why I am telling you this? Can you see the presence of what is known as pencil cells? Yes, it's very specific for iron deficiency anemia. And not only that, there is microcytosis. Along with that, if you see the central pallor, if you see, it is more than 1/3. Okay, so actually in this slide we are seeing both microcytosis as well as hypochromia. So this is microcytic hypochromic slide. Usually they are very much indicative of iron deficiency anemia. So absolutely you will have to carry out further investigations so as to confirm idea. Okay, but this is a classical picture of microcytosis along with hypochromia. Okay, now if you look over here, now we are going to see what is macrocytosis. So if you see, this is basically the small lymphocyte nucleus, and if you compare it with the nearby RBCs, so the RBC size is larger as compared to the size of the nucleus of the small lymphocyte. This is called as macrocytosis. Okay, okay. So if you look at the macrocytic RBCs, so if you this is the small lymphocyte, this is the nucleus of the small lymphocyte, as we can appreciate. But if you see the macrocytic RBCs, they are larger compared to the size of the nucleus of the small lymphocyte. So what are the causes of macrocytosis? Now remember one thing, there is a difference between megaloblastosis and macrocytosis, so do not confuse. So please listen very carefully when the examiner is asking you what are the causes of megaloblastic anemia or megaloblastosis. So you lay down all those causes, but when he is asking you the causes of macrocytosis, that means when the RBCs are enlarged. So the causes can be divided under two headings. So macrocytosis can be because of megaloblastosis, or the causes can be non-megaloblastic. So megaloblastic causes includes B12 and folate deficiency and all the causes underlying them. Okay, so all the causes underlying them are also the causes of megaloblastic macrocytosis. So what are the non-megaloblastic causes of macrocytosis? So alcoholism, okay, liver disease, hemolytic anemia, hypothyroidism, and also MDS. So over here you can just remember LHMC, Lady Hardinge Medical College, as the short form or as the mnemonic. So L stands for liver disease, H stands for hypothyroidism, M stands for MDS, and C stands basically from chronic alcoholism. Okay, so this is basically the short form or the mnemonic for non-megaloblastic causes of macrocytosis. Now we are going to discuss about the abnormality of the red cell hemoglobin content. So very importantly, we have to understand one important thing over here, that RBCs, okay, RBCs which are having abnormal hemoglobin content, most commonly that we encounter is a decreased hemoglobin content, that is hypochromia. So what are the causes for the same? The causes is CETA. So the same causes of microcytosis are also forming the causes for hypochromia. Now what is dimorphic anemia? Wherein you are finding both normochromic RBCs along with hypochromic RBCs. So what are the situations that you can encounter dimorphic anemia most commonly in the day-to-day practice? So for example, there is a patient of iron deficiency anemia who is receiving treatment. So iron deficiency anemia patient who are responding to treatment will have both microcytic hypochromic as well as normocytic normochromic RBCs. Along with that, very commonly following blood transfusion in a patient with hypochromic anemia, again over here you will see a dimorphic picture, and less commonly you also encounter the same in sideroblastic anemia. This is the first situation. Okay, so normochromic along with hypochromic RBCs. Again, the second clinical picture is microcytic hypochromia along with macrocyte, which is classically encountered in myelodysplastic syndrome. So this is about the RBCs with abnormal hemoglobin content. Okay. Okay, now also what is very important over here, this is the dimorphic picture that we can see over here. So there's a small lymphocyte over here. You are having normal RBCs along with microcytic hypochromic RBCs, the causes being CETA. Okay, so this is when you are giving treatment to the patient. For example, iron deficiency anemia patient receiving treatment, or for example, you are giving blood transfusion to the patient who is suffering from CETA. Okay, now along with that, I would also like to tell you something about an abnormal shape of the RBC, that is the spherocyte. So what is a spherocyte? We will discuss it again under the heading of RBCs with abnormal shape. But first, what is a spherocyte? Always remember, if this is a normal RBC, remember a spherocyte is that RBC which is smaller as compared to the normal RBC and which is lacking central pallor. I repeat, a spherocyte is that RBC which is smaller as compared to a normal RBC and it is lacking the central pallor. Because it is small as compared to the normal RBC, they are also called as microspherocytes. Spherical and smaller RBCs staining more intensely than the normal RBCs and loss of central pallor. So they show characteristic increase in the MCHC. Okay. So what are the conditions where you see them? Characteristically in hereditary spherocytosis, autoimmune hemolytic anemia, the worm type, and ABO hemolytic disease of newborn. Okay, so now you must be thinking that why, sir, morphology of RBCs is so much important? Because if you are writing the morphological diagnosis in the peripheral blood smear report, then the treating clinician can get an idea as to the probable cause of the anemia. So what is the morphological classification of the anemia? So very important, microcytic hypochromic anemia, wherein the MCV is less than 80, MCHC less than 30 gram per deciliter. So what are the conditions where you get this? Again, the condition is SITA, that as I've already explained. S stands for sideroblastic anemia, iron deficiency anemia, thalassemia, and anemia of chronic disease. Okay, then we are having macrocytic anemia, where the MCV is more than 100, MCHC is between 30 to 35 gram per deciliter. So the causes can be megaloblastic and non-megaloblastic. So we have already discussed about this. Okay, so we are not repeating once again. And then very importantly, normocytic normochromic anemia, wherein MCV and MCHC, both of them are under the normal range. So how do you, how do you divide them, or how do you classify them? So you have to go for the retic count. If the retic count is increased, then in that case, it can be because of recent blood loss or because of hemolysis. If the retic count is decreased, then these are indicative of some defect in the bone marrow or certain systemic disorders like aplastic anemia, chronic renal failure, anemia of chronic disease, or anemia due to infiltration of the marrow. Okay, so this is the classical morphological classification of the anemia. So this is very commonly asked in your practical exams. State the morphological classification of anemia with causes. Now we are going to discuss about the abnormality of the RBC shape. So the very important thing, as we know, any abnormal or variation in the RBC shape, we call it as poikilocytosis. Marked poikilocytosis is characteristic of congenital dyserythropoietic anemia, myelofibrosis, and hereditary pyropoikilocytosis. Now, specific types of poikilocytosis, again, very favorite examiner question, very important viva question. Okay, so the first important type is sickle cells. As you can see, the RBCs are in the form of sickle. They are also called drepanocytes. So in the exams, they might not use the word sickle. They might just use the word drepanocyte. So you have to understand, sickle cells are also called as drepanocytes, and classically they are seen in conditions of sickle cell anemia. Okay, so this is the first condition, that is I am showing you poikilocytosis. So if you see the RBC shape over here, see the RBC shape over here, see this shape over here. So there is an abnormality of the RBC shape. They are of different sizes, of different shape. Okay, over here. Now, very importantly over here, now these are the sickle cells that we can appreciate over here in this PBS. So you can see the characteristic sickle cells which we see in sickle cell anemia. Okay, so such exam slides are kept. So you should be very much, you should have a morphological image in your mind about the same. Okay, so spherocytes, okay, we have already seen what the spherocytes are. So if you compare it with a normal RBC, they are smaller and they are stained more intensely with no central pallor. Okay, these are the basic features, and we know the causes: hereditary spherocytosis, autoimmune hemolytic anemia, worm type, and ABO hemolytic disease of newborn. Then we have what is called as the presence of cystocytes. The cystocytes are also called as fragmented cells or helmet cells. Okay, why fragmented? Because they have surface spicules or projections. So you can see over here the cystocytes as if they have been fragmented. This is a normal RBC, you can see, and these are the fragmented RBCs that we can appreciate over here. Let me just change into some other color, so you might be able to appreciate that better. Okay. So basically over here, if you see, okay, basically over here, if you see, just one second. So this over here, you can see this is the normal RBC, and this you can see as the cystocytes or the fragmented RBC. So what are the conditions where you see cystocytes? Very important, all the conditions of MAHA, that is microangiopathic hemolytic anemia, like TTP, HUS, and DIC, as well as in conditions of severe burns. Okay. Okay, so this is very important. First, you try to understand this is a normal RBC. They are having central pallor over here. And over here, if you see, this is another RBC over here, but it is smaller as compared to the normal RBC, and there is no central pallor. So these are basically your spherocytes, as we can appreciate over here. Now these are the cystocytes. You can see the helmet cells or fragmented cells. Okay, pointed spicules can be appreciated over here in this particular pattern. Okay, also you can see these fragmented cells over here, as we can appreciate over here. Okay, this is basically your cystocyte. These are basically your cystocytes. Okay. Now, very importantly, the other shapes are, we are seeing over here, the target cells. Or the target cells, they are also called as the podocytes, also called as the Mexican hat cells. Okay, so if you see basically over here, these are the normal RBC. So if you see the target cell, somewhat looks like this. The central stained area is there and a peripheral film with unstained cytoplasm in between. So in between the central dot, there's a central stained area and there's a peripheral stained area. Okay, and in between the area is completely clear, unstained. Okay, so where do you encounter target cells? They are classically seen in hemolytic anemia and the different varieties of hemoglobinopathies like thalassemia, sickle cell disease, HBC disease. They can also be encountered in obstructive jaundice and following splenectomy. Then we see the presence of what is known as Burr cells or echinocytes. So these are small red cells with a regularly placed surface projection. So there is a regularly placed surface projection. So when the surface projections are regularly placed, we call it as Burr cells or echinocytes, and they are characteristically seen in uremia or chronic renal failure. So we can appreciate over here the target cells classically, the central stained area and the peripheral stained area. In between there is a unstained area. So these are the target cells, as we can appreciate over here in this particular diagram. Now these are the Burr cells. Now if you look at the Burr cells, classically the surface projections, they are evenly spaced. They are evenly spaced, seen mainly in case of CRF or uremia. Now the next variety wherein also you can see the surface spicules, but these spicules, they are very unevenly spaced. Okay, so this is something called as the acanthocyte or the spur cells. Okay, so the red cells with irregularly placed surface projections. Okay, if they are regularly spaced, they are called as Burr cells, else they are called acanthocytes or spur cells. Where do you see in spur cell anemia of liver disease following splenectomy and a beta lipoproteinemia condition? Okay, then we see keratocytes or horned cells, so red cells with 2, 4, 6 spicules due to mechanical damage, again a feature of microangiopathic hemolytic anemia. So here we can see, okay, the surface projections, if you see, they are not uniformly spaced. Okay, so they are not uniformly placed, as we can appreciate over here from this diagram. So these are called as the acanthocytes. Okay, then very importantly, one very important cell that you very commonly encounter is the teardrop cell. What they are called as? They are called as dacrocytes. Do not make a confusion between drepanocytes and dacrocytes. They are different. Okay, drepanocytes, they are the sickle cells, dacrocytes are the teardrop cells. Okay, so very important, these dacrocytes are, these are those RBCs which have tapering drop like shape. So you can see over here pear shaped. Okay, so they have a tapering drop like shape. These are the normal RBCs. So they are classically seen in conditions of myelofibrosis, myelocytic anemia, thalassemia major or megaloblastic anemia. Next we have the blister cells or hemighost cells. So over here, this is basically the normal RBC. Over here we can see hemoglobin is contracted and condensed away from the cell membrane. So you can see only a part of the cell has been stained over here. Okay, so this is called as a half host cell, classically seen in the acute episode of G6PD deficiency. Okay, so you can appreciate the teardrop cells. So let me show you, these are the teardrop cells. So one of the end is classically tapered. These are the teardrop cells. See another teardrop cell over here. Okay, very importantly, these are the bite cell, as if someone has bitten a portion of the cell. These are the bite cells. Okay, as we can appreciate, these are classically seen in G6PD deficiency. Okay, so the bite cells, as I was just telling you, it occurs due to the removal of Heinz bodies by pitting action of the spleen. So what happens that those RBCs which are G6PD deficient, they are subjective to oxidative damage. So as a result, when they are going into the spleen, so what happens, the splenic macrophages, okay, they are going to bite off a portion which is containing the Heinz bodies. Okay, so very importantly, it occurs because of the removal of the Heinz body by pitting action of the spleen. They are classically seen in G6PD deficiency and unstable hemoglobin disease. Then we are having elliptocyte. These are rod-like RBCs, the red cells with its long axis. If it is more than 2 times the short axis, okay, like this, it is called as an elliptocyte. If it is less than the 2 times the short axis, then in that case they are called as ovelocyte. So very commonly asked exam question, what is the difference between elliptocyte and ovelocyte? Okay, and elliptocytes are classically a feature of hereditary elliptocytosis. Then we have stomatocytes, which are also called as mouth cells. So they occur in alcoholic liver disease, alcohol excess or hereditary stomatocytosis. Then we have leptocyte. These are thin cells or wafer cells seen in thalassemia or obstructive liver disease. Okay, so with this we have completed the discussion on the red cells with abnormal shape. Now we are going to discuss about the red cell inclusions. Okay,